It's a great pleasure to be here this morning, and I want to thank the organizing committee, the foundation, and all of you for participating in this event. I want to talk a lot about the experience that we had in really looking at how to implement a program which engaged our patients and their families in planning for future health care. Perhaps a little introduction might be helpful. I'm a philosopher by training. When I was in graduate school, I never imagined that I would spend my career working at a health organization or leading an effort to improve patient care. But that's exactly what ended up in my life. So for 32 years, I worked at a large integrated health system in La Crosse, Wisconsin. And as an ethicist who was training physicians professionally and ethically how to take better care of patients, I encountered the frequency in which we had to make serious critical decisions for patients in the hospital. And the biggest uncertainty that we faced was not knowing what the patient wanted us to do. Neither the family knew nor the physicians knew. What struck me as an outsider in this circumstance is that these patients were our patients, patients who saw our doctors, who had been in our hospital previously, who were receiving dialysis from our dialysis unit. These patients were familiar to us. We knew that they would get sicker. We knew that at some point we would face a crisis. But in no place in our system did we engage our patients and their families in asking them what was important and when the goals of care might change. We had every opportunity to do this, but we did not. I started to raise the question, why didn't we do this? And I received many answers from physicians in particular. And the answers were that, well, patients don't want to talk about this, or we will upset them, maybe even distress them. And so there were a lot of reasons given, but none of those reasons were based in any evidence or any fact. And so I convinced our administrative leaders and our physician leaders to give me an opportunity to try to create a program, to implement a program for a small population of patients with chronic illness. These patients, there were about 60 of them, had kidney failure and were on hemodialysis, where they came into our dialysis unit 3 times a week for a life-sustaining treatment. So we sat about the project of determining how conversations would occur. When would we approach the patient? Who would be involved in the conversations? Who would conduct the conversations? What would we do with the information that came out of that planning session? How would it get into the medical record so it would be available to the emergency room physicians and other people and physicians in the hospital should this patient get very sick? We solved all of those problems, and within 2 years of implementation, over 50% of the patients in the dialysis unit had a written plan in their medical record, but more importantly, the uncertainty that we faced at the end of life for all of these patients almost completely disappeared. We almost always knew what the patient wanted us to do in that moment of crisis. Not only did we know, but their families knew. And so we proceeded with decisions, whether that was to continue or to discontinue dialysis. We always made a decision with great confidence. And we realized that this was a better form of care. We later decided to extend this pilot program to the whole community. And briefly, what we now know in our community of La Crosse County, of about 125,000 people, that 96% of the time when an adult faces death in any health organization, they have a written plan. That written plan is available at the site of care where decisions are being made, and the preferences of the patient are consistent with the treatment choices or decisions made 99% of the time. Advanced care planning has made our health system in La Crosse person-centered. It has also helped us to integrate in a way that we never had before. That is, information about who this patient is and what they value is transferred across setting of care. Before I go further, though, I would like to invite you to attend an international meeting on advanced care planning as the interim president of the International Advanced Care Planning Society. This will be held in Banff on September 6th to 9th. I have reviewed many of the abstracts. It's going to be a fabulous conference with some of the best work in advanced care planning from Europe, from the United States, from Canada, from New Zealand, from Australia, from Singapore, from all over the world. I encourage you to attend if I can put that shameless plug in here. The program that I've helped develop is characterized in many ways, and I want to start by dispelling some of those misconceptions. The program called Respecting Choices in the United States is often thought of as an initiative to promote advanced directives. It's sometimes thought of as simply a training program for what we call advanced care planning facilitators. It's also thought of as a program to improve end-of-life care or only end-of-life care, and sometimes people think that the program has only been successful in La Crosse. These interpretations or views, each one of them at least separately, are incomplete for sure, and in some cases simply wrong. The Respecting Choices program, I think at its core, is a program that assists health organizations and communities to redesign their processes of care and interactions with their patients and families so that decision-making, including planning for future health care with patients and their families, is conducted as person-centered shared decisions. And I think each of those concepts of person-centered and shared decisions is really important. This program is often thought of as a program to promote self-autonomy or patient autonomy, to focus on patient rights. We don't actually conceive of it that way, although I'm comfortable with that concept. We think that advanced care planning is trying to answer this fundamental question. What does good care look like for this person, from this person's perspective, particularly if they became seriously ill? This is the question that we always ask in healthcare. What does good care look like? What is the right care for this person right now? In our program, we believe that planning and decision-making is always grounded in that question. What does good care look like for you? So we think of advanced care planning as actually not the end, but the tool to develop a system of healthcare that's person-centered using a shared decision-making process. So what is the desired outcome of advanced care planning? The desired outcome, in our view, the thing that we would want to know is, do we know what this person wants, even if they become incapable or unable to make their own decision? And will we be able to honor their preferences, which are informed and thought out? Now, to achieve good planning, we think three separate but important elements are important. First of all, to create a planning process that's effective. That planning process starts, ideally, with a well-prepared, what we call healthcare agent or proxy, someone who the patient would trust and who's capable of making decisions if the patient becomes incapable. Now, even without a legal structure, even if this is not recognized by some law or statute, it is possible for the patient to identify a person as an informal request of who they want. Or, if it isn't a person, it may be a process. We can create specific instructions with this patient that are informed and thought out, that really reflect their values and goals, but are also geared to the state of health of the person. And I'm going to talk a bit more about this, about the idea that as people get older and sicker, we need to come back to the planning process a number of times. But having the best plan in the world, having the most thought out plan in the world, is not helpful if it's not available to the people who are making decisions when a crisis occurs. And I don't have to tell you, because I've heard in the presentations both yesterday and today, the efforts that are being made at improving communication. It is very clear that the success that we have been able to achieve in La Crosse has in part been due to the fact that we have set up effective processes not only to plan well, but to capture those plans in standardized documents, get them into the medical record, and be able to keep them with the patient as they move through the health system across settings of care. Some of this is done electronically, some of this is just the kind of very basic copying paper and sending it as people transfer. And finally, we have to assure that plans are incorporated effectively and correctly into decisions when that is actually needed. So we have to train physicians to know how to look at these plans, understand them, interpret them, and apply them correctly. Now, what is an advance directive? In the United States, this word is often associated with a legal document. And that clearly is a correct definition, but we think it's a too narrow definition. So in our approach and in our program, we think an advance directive is any plan created by a capable person, or sometimes by their surrogate if they're authorized, for future healthcare decisions that reflect their goals and values. The plan might be communicated in many different ways. It may be communicated through a legal document. It may be communicated by a physician's note. We actually have patients who write letters. Dear doctors and nurses who provide my care, I want you to know the following things about me. All of those things, we think, if they authentically capture what a patient believes and values, should become part of the medical record, can become part of the medical record, and can assist us in making the best decisions possible. So we have to think about the planning process, and we have to think about how the plan is communicated. We do have patients who say, I don't want this written down, but I want my family to understand, and the family becomes the transmitter of the information across settings. Now, I don't think that's quite as reliable. It makes me a little nervous, but if that is the preference of the patient, we also respect that. The planning process isn't just the process of filling out a form. The planning process needs to have some very specific qualities to it. And perhaps the most important that I think is undervalued and underappreciated is the value of reflection that the patient or person goes through in understanding themselves. What we have come to realize is that if you ask a patient what's important to them, the first answer they give you may not and is often not the most important. They often give expected answers. It's kind of like when someone says good morning to you, you may say good morning back because that's expected, even if you're not having a good morning. Patients are very similar. If we just ask them what they want, they may say, oh, I want to be healthy and I want to be comfortable. But there may be something underneath that that is more important, more detailed, more concrete, and we have to explore that. Now, we're not trying to lead patients into one view or another, but we're helping them articulate who they are and how healthcare can help them be who they are. We also have to help them understand what advanced care planning is and why it's important, and what are some of the situations they may need to think about, and ask them about when goals of care might change. And finally, in this process, it becomes particularly important since the patient is planning for a time when they may not be capable, and their families may become responsible for their decision. Their families understand directly from the patient what the patient thinks. So facilitating that discussion with those who are close to the patient and the patient has chosen is really important. Now, to do this effectively, we think that planning should be done in stages. It's simply not possible to plan for everything at some particular moment in time. And so we have created a strategy for planning over the lifetime of the patient that follows the course of chronic illness. This graph or depiction here is the idea of the patient's function and health status declines over time once particularly they have a chronic illness, and the dips in that line represent acute episodes or hospitalizations. So we would like to start planning early when people are relatively healthy, but often not until mid-age. And here we want to plan for two things. Who would make your decisions if you became incapacitated? And if you suffered a serious neurologic injury from which you would not recover, when would that be so bad that the goals of care for you would change? Because this is a decision which could happen to any of us. We could be struck by a car or have a car accident, and we could have a neurologic injury from which we wouldn't recover. What would our families decide, particularly if it was possible to keep you alive for a long period of time? Would you want that? Perhaps. Or would you not want that? This is a terrible decision for a family to make when they have no understanding of your values or goals. The second stage of planning occurs when the person has a serious illness but is starting to suffer frequent complications. Here, we want to engage them in a very disease-specific planning process because they now have a disease which is serious, help them understand what the progression of that disease is, but explore their values and goals in a way which will help them answer when, if they had a complication, and despite our best treatment they had a bad outcome, when would a bad outcome lead them to want to change their goals of care? Interestingly, we have found that this process of planning actually helps patients be more engaged in their healthcare decision-making while they're still competent, and they make different decisions. And then finally, we have what we call last steps, and this is focused on people whose prognosis is a year or less. And here we want to really focus on, given this prognosis, what are your goals for care, and what kind of emergency care would you want if you suffered a cardiac arrest or severe cardiopulmonary deterioration that is life-threatening? And these decisions then are actually documented as medical orders which are transferable across settings of care and may be followed by emergency services out in the field. So in La Crosse, our patients have first steps engaged in middle age when they're still healthy. We add next steps when they develop a serious illness and start having serious complications, and then we add last steps when we get into that last phase of life. So when patients come into our emergency room, not only has this planning been accomplished, but it's available, and it allows our emergency room physicians, our surgeons, and other specialists to evaluate and make different decisions already in the emergency room because they have this wealth of information that's well documented and captured. If you've understood these concepts, what you can see is the quality of the planning process is directly related to the quality of the plan. If we shortchange, if we skimp, if we take shortcuts in the planning process, we will end up with a plan that's incomplete, misunderstood by the patient, not understood by the family, not communicated well, it's not helpful. So to be successful, we have to create a system where the prevalence of planning is high, and we have achieved that in La Crosse, 96% at the time of death. Specific enough so it's useful for clinical decisions. It has to be accurate of who this person is. So those people who want more, we know they want more. Those who want less, we know they want less. They need to be understandable so that we can make decisions. They need to be available, and ultimately they need to be incorporated. So I want to talk a little bit about the importance of creating a system and thinking about this as a system, not just in a single organization, but across the community. In every healthcare organization around the world, as far as I can tell, we all do pretty much the same thing when a patient, say in a hospital, has their heart and breathing stop. If a patient is in a hospital and they want CPR to be attempted, and they're found to have no heartbeat and no pulse and no breathing, quickly a team is identified through a process. The team that comes are certified in advanced cardiac life support. They know their roles and responsibilities. They have the equipment to perform ACLS. All of this process is monitored by a resuscitation committee. Now imagine that this process is thought to be too expensive by an administrator, and they decide to eliminate the training or the communication system or the drugs that are needed in the crash cart. The patient's going to die. If this system becomes disorganized, the patient will not survive. In the United States and in most places of the world, the efforts that have been made to improve advanced care planning have been made by unorganized, disorganized, and poorly managed systems. It will not work. In order to be effective, we need to make advanced care planning a system. Now, I don't have time to go into this system analysis too far, but I have tried to outline in a few bullets what a system might look like in long-term care. First of all, it starts with high-quality planning. Then we need a set of standard planning documents so that we can document this in a way which can communicate to everyone who needs to know. We need that these documents actually stay with the patient and are available. We need to train physicians to know how to use this information reliably and effectively and appropriately. And then ultimately, in these studies I've seen and worked with, the nursing home in particular has to be able to provide the palliative services that are needed so that when residents of that facility say, I want to stay here but be comfortable, we can actually honor that preference. So what does the data suggest? And this is from multiple studies done in different parts of the world. It is possible with an effective system in long-term care or nursing homes to increase the prevalence of planning to very high levels. Patients will engage in this planning. When the planning is done well and correctly in a person-centered way, it improves the satisfaction not just with the planning, but with overall care. It decreases the utilization of hospital services. And it decreases, importantly, based on some of the comments, the negative emotional symptoms in close family members after the death. One study out of Australia showed that family members who did not participate in good planning suffered such dramatic emotional negative consequences that they would suffer something like post-traumatic stress syndrome. To be effective, however, we have to have a quality process, appropriate documentation, and competent and skilled palliative services where appropriate. Finally, I'd like to talk about the use of facilitators. Why use advanced care planning facilitators? These are typically nurses or social workers who are trained and certified to provide a service to the patient and their family. There's 3 points I would like to make here. First of all, our common experience worldwide, starting at the Gundersen Health System in La Crosse, Wisconsin, is that most physicians do not have the time that's needed, and some are simply not willing, to provide planning for future healthcare decisions that is actually needed by patients, residents, and their families. The second point is patients do not come to these decisions with clear and well-articulated ideas about their values and goals. It takes a considerable amount of skill and time to assist them to be clear about what they value and what goals they have. And then finally, discussions among family, which are really important and crucial to make this work, are at best challenging. And when an outside, independent, trained guide isn't available, I think for many families, they become impossible. So to make this discussion possible, facilitators play a crucial role. Thank you, and I look forward to your questions.